All right, good morning or afternoon, everybody. My name is Mike Hess, and this is COPD Navigator Live. For those of you who might be new to the show, this is our weekly look into the world of COPD, chronic obstructive pulmonary disease, and some tips and tricks for living with it, helping to manage it, and living your best life. First off, we'll start this week with a little bit of COPD news. It's been a little bit of a quiet couple of weeks now. We've been off the air for a couple of weeks due to some very hectic scheduling things going on. But first off, we'll take a look. There is a new study out from Harvard that's been announced in the last few days that tells us that women with rheumatoid arthritis are actually 68% more likely, according to this study, to come down with COPD regardless of their smoking history. This is even controlled for things like age and hormone supplement status and pretty much every kind of comorbid condition or confounding factor you can think of. Still the risk is much higher. And while this may seem to be kind of an obscure point of detail, the biggest takeaway here is that in cases of rheumatoid arthritis, we do tend to see a lot of inflammation. And we also know, as we have an increasing body of knowledge that tells us that inflammation throughout the body is a key contributor to the worsening of COPD, the development and worsening of COPD. So this is basically even more confirmation that inflammation and inflammatory mediators are a big deal when it comes to COPD, and those conditions that can increase the amount of inflammation throughout your body, things like arthritis, things like even as simple as obesity or being overweight, can have a big impact on your breathing. They can either set you up for potential lung disease, or they can make any existing lung disease worse. So that is definitely something to consider as if you have a systemic inflammatory disease and you're starting to have some breathing issues, get yourself checked out right away and see what we can do to minimize the progression of that disease. Some other news on a more local basis. Last week, I hoped to broadcast this out, but unfortunately we weren't quite able to work out some of the technical issues. We had here in southwestern Michigan our first annual Shining a Light on Lung Disease symposium. This concept was sponsored by the Michigan Society for Respiratory Care and the Western Michigan University Homer Stryker MD School of Medicine, and was intended to break down some of the barriers between specialty practitioners, such as those involved in pulmonary rehabilitation, pulmonologists, respiratory therapists, a lot of other groups, and try to bring that expertise more into focus in the primary care world. We see an increasing amount of evidence and recommendation that lung diseases are most ideally managed throughout primary care. These are situations where we can't necessarily wait to go to the emergency room or the urgent care or even wait for a pulmonologist appointment to manage this stuff. This has to be kind of an ongoing educational experience, ongoing patient management, and building that relationship between our specialty groups and our primary care practitioners is incredibly important. So it was a very successful event. We had a great turnout from throughout the primary care community. We had care coordinators, we had nurses, we had respiratory therapists, we had physicians, we had clinicians of all stripe coming out to learn from some of our expert panel on things like cystic fibrosis, asthma, sleep apnea, pulmonary fibrosis, and of course COPD. It was a very successful event, as I mentioned. We are definitely looking at creating or following in the footsteps of this with another event next fall, and we are also examining, looking at how we can create a similar event more directed toward the patient and caregiver community. We are very interested in trying to increase knowledge, of course, throughout everybody whose life is touched by chronic lung disease. And we want to bring access to specialists and other involved parties in the community to as many people as we can. So hopefully we're looking at something this spring here in Kalamazoo. And we can follow in the footsteps of successful events like the American Lung Association's Lung Force Expos throughout the country, and this summer's COPD 10 USA, which was a very patient-centered event, and did a great job with bringing the voice of the patient and the caregiver to bringing all the groups together to learn from each other. So that's kind of the latest news updates. Also, you may notice, well, hopefully you'll notice later on today, we're trying a little bit new experiment here. We've got some new technology, new equipment brought in, so that it will hopefully make it a little bit easier to get some of our future episodes recorded onto YouTube. Unfortunately, we've had a lot of issues, what we call transcoding some of the older episodes onto into a format where we can put them on YouTube. And so it's been very time consuming and unfortunately has limited some of our archival offerings. But trying something new today, like I said, we've got a little bit of new technology, and hopefully that'll make it easier to put this and future episodes onto YouTube for reference purposes. So be on the lookout for that. I'll be posting in our group later on as soon as I can get this uploaded. As to our group, if you're new to the COPD Navigator live experience here, we do have an excellent Facebook group, facebook.com/groups/COPD Navigator, where we have an outstanding community of people living with lung disease, people caring for people with lung disease, and clinicians and other medical professionals who offer a great deal of support, great deal of knowledge, great deal of expertise. Again, trying to get people to live their best lives throughout the spectrum of lung disease, particularly COPD. So our topic for today, our name of our game today is acid-base trip, because we get a lot of questions about blood gas analysis. The whole concept of blood gas analysis comes from looking at oxygenation status, looking at carbon dioxide levels, looking at a few other components of stuff that's dissolved in the blood, so that we can kind of get a better idea of a person's overall clinical picture. There are a couple of key components to, first a little bit of background on why this sort of thing is important. Your body exists in kind of a balance between acids and bases. Everybody's probably heard of the pH scale, where we have very acid things like hydrochloric acid and all that stuff on one end, very base things or alkaline things like sodium hydroxide, on the other end. Our body wants to live fairly close to the middle of that range, what we call the neutral area. And you have two main drivers of that inside of your body. First off, you have carbon dioxide, which when dissolved in a liquid actually is a little bit acidic. And you have bicarbonate, which is the buffer to that, or the opposite to that, and the base. And those two chemicals need to live in harmony so that your cells can do their cellular business and you can continue to survive. When those things get out of whack, then we start seeing various issues throughout the body. Cells don't work as well. Your brain can get a little fuzzy sometimes. We see a lot of issues involved in your chemical balance. Now, of course, when you have obstructive lung disease in particular, it's difficult to get the exhaled out. Carbon dioxide is a waste product that we tend to exhale out so that we can keep everything fresh. But when you have that chronic obstruction, it's difficult to get that air out, so carbon dioxide tends to build up in the lungs, where it tends to kind of back up in the bloodstream, and you tend to have excess carbon dioxide throughout your bloodstream. And your body has to deal with that. That's kind of one of the hallmarks of a chronic obstructive lung disorder. It's called hypercarbia, or the presence of excess carbon dioxide in your system. Now, of course, your body can adapt and can make certain accommodations to try to counteract those buildup of one chemical or the other. In the case of carbon dioxide, it counts on your kidneys to generate more of that bicarb, that buffer, and keep everything into balance. And so the whole point to all of that is we can take a look at a sample of blood, find out how much carbon dioxide is in it, find out how much oxygen is in it, get a few other, depending on the technology level of the lab that's doing the analysis, we can get a lot of other information from the blood gas and get a very good picture of the person's overall clinical health. And we get all that stuff in a blood gas analysis report, which we could probably spend an entire hour or even more on. This is a very complex topic. There's a lot of new information coming out all the time about what is important about a blood gas, how can we best analyze it, what do changes mean, what all the different numbers mean. For simplicity's sake, because a lot of that stuff is very much in the realm of critical care medicine or some very advanced topics, we're going to try and keep everything at kind of a fairly low level today, so that when you go, if you happen to be in the hospital or if you happen to have your clinician order you to get a blood gas analysis, you can have a little bit clearer picture of what the numbers mean. The first number we look at is the pH value. This value, again, we want to keep it fairly close to the middle of the pH range, which is officially 7. Your body actually exists right around 7.40, so it's just a hair on the base or the alkaline side of fully neutral. And because everybody is a little bit different and there are some normal ranges in there, we usually look at keeping things between 7.35 and 7.45. That's what we call the normal range for pH. pH is arguably one of the most important values, because, as I said, your body systems do tend to have a pretty good capacity to compensate for problems on one side of the scale or the other. We'll get into that in a little bit more detail in a little bit. But the pH is kind of the first thing that triggers us to keep an eye on things and to give us an initial indication of how well or how poorly a person is doing, particularly in an emergency situation. The next value that we usually look at is also incredibly important. This is what we call the PaO2, sometimes just the PO2. This is the partial pressure of oxygen that's dissolved in your blood. Of course, oxygen is what makes the good air coming in so good. This is one of the main fuels, one of the main energy components to your cells. Obviously very important. We want to make sure that we're getting proper oxygen. Our level that we consider the normal range here is 80 to 100 millimeters of mercury, or sometimes you'll see it recorded in torr, which is basically the same thing as Torricelli. It's a unit of pressure named after an Italian scientist named Torricelli. Basically we're looking for 80 to 100 there to keep everything in the normal range. When we start getting lower than that, then we start getting into that area of what we call hypoxia, or not enough oxygen, basically. And that's when we start looking at how do we increase the oxygen. Do we need to look at recruiting some of those lung units? Do we need to just give somebody some extra, some supplemental oxygen through a cannula or something similar to that? What do we need to do in those situations? When we start going over 100, then we can start cutting back on those supplemental oxygens. A lot of times we look at blood gases on people who are on ventilators in the hospital, and we can start turning down their oxygen, getting ready to liberate them from the ventilator. But we can also look at that as somebody is on large amounts of supplemental oxygen. For example, when they first come into the ER, when they're having an exacerbation or something like that, when we can start tailoring some of that stuff down. Part 3 is of great interest to many in the COPD community, which is the partial pressure of carbon dioxide, or the PaCO2, PCO2, whatever your particular lab decides to label it. We look for a normal range here of 35 to 45 millimeters of mercury, or 35 to 45 torr. And again, we start getting a little bit concerned when we get outside of those ranges, because particularly when you have high levels of carbon dioxide, as many people with obstructive lung disease have, then you start having some of those mental side effects. You start getting a little bit drowsy, you start getting a little bit confused, you start getting in some of those areas there. And that's where we start running into problems. Fortunately, your kidneys, it takes a little bit of time, but they are able to buffer that a little bit and bring yourself back into that normal pH range. And the last thing we look at on a blood gas, generally look at on a blood gas, is what we call the bicarb number, HCO3, which is the chemical formula for bicarb. And this is a different unit on here. This is millimoles per liter, but we also look for a range of 22 to 26. And on here, I don't know how well you can see it, I actually wrote 22-ish to 26-ish. One thing we find that many labs have their own particular preferred normals. We have kind of this overall concept of what we want to see for a normal, but some labs are a little bit, for various reasons, are a little bit to one side or the other. So sometimes you'll see one lab say a normal is 23 to 26, or 22 to 26, or 22 to 25. These minor variations tend to not have too much impact on clinical decision making or anything like that. They're just, it's almost a type of personal preference. One thing that some people look at on blood gas analysis is this concept of the base excess. And this is a little bit arcane. This is, again, a lot of times what we look at as a clinician to try and figure out what's going on. This is kind of a measure of how much of the if something is out of whack, how much of that is being contributed by the metabolic component. Looking at the base excess, whether it's positive or negative, kind of gives us a better idea of how much of the issue is metabolic or created by the kidneys or that sort of thing, and how much of it is respiratory, created by the lungs. For the most part, when we're talking about COPD, that's what we're talking about. We're talking about how much the acid-base imbalance is contributed by the lungs. Again, when you have that obstruction, you have that buildup in the lungs, and have that stale air staying in there, and you're not able to flush out that carbon dioxide, that's going to stay in your blood system, in your circulatory system. It's going to stay in your blood. And your body wants to compensate for that. So it puts a little bit more load on the kidneys to put out more bicarb, and we start seeing what we call compensation. And this is, again, sometimes you'll see people get kind of worked up because, well, okay, my carbon dioxide is 50. And it's actually fairly common for people with COPD to have carbon dioxide levels in the 50s. The question then becomes, how well has it been compensated? Because if your CO2 is in the 50s, but your pH is normal, then we know that yes, you're trapping air, you're retaining carbon dioxide, as I say, you're a retainer. But if your body is able to compensate for that and get your pH back within that normal range, it's certainly not an acute problem. It's something that we probably already know about. Again, it's something we expect to see in the COPD community, and it's something that we can manage on a chronic basis. But if your CO2 is 50 and your pH is down in the acidic side, like maybe say 7.3 or something along those lines, then we know that you're having an acute problem. We know that you're having an exacerbation most likely. We're seeing that your carbon dioxide levels are what we call acutely high for some reason, whether it's you're having a symptom flare, whether your kidneys are having some trouble. Then we start investigating the causes a little bit more, and we start looking at how we can resolve the situation and get your pH back to a normal range. This is one of the most difficult things to remember as a young clinician or as a student. We see those numbers kind of get out of whack sometimes, and we immediately want to make a change in the ventilator, or we want to treat a person more aggressively. But then we look over at the pH and we realize, well, okay, this is probably kind of normal for them, and we need to be focused on making sure that they don't leave that range again. We don't necessarily want to come back to be too aggressive, because then we end up getting into an alkalosis type of situation where you have all that buildup of bicarb from your kidneys in your body, and then you don't have the carbon dioxide to balance that out anymore, and that can cause issues in and of itself. We don't necessarily see as many metabolic issues in the COPD population because your more urgent issue is respiratory related, and also your lungs are much able to more quickly change their impact, I guess, so to speak. You're able to have much more control over the level of carbon dioxide in your body than you are with your bicarb. The kidneys are very effective, but they're slow. You can change your rate of breathing. In many cases, you can change it voluntarily. If I were to sit here and go for any particular length of time, I would probably start getting a little bit dizzy myself because I'm blowing off too much carbon dioxide. I'm throwing my acid base out of my acid base equation, out of my acid base balance, out of equilibrium. Ooh, that was difficult to say. And I'm having an impact on my blood chemistry. Your kidneys take a much longer time to have that impact, usually more along the lines of hours or even days rather than seconds or minutes. And so we tend to look at affecting carbon dioxide as a more acute situation and making sure we can get that stuff out of control or into control. And before we fired up today in the group, we actually had somebody ask, had a couple of questions preloaded here. One of them was, what is hyperventilation and how might that apply to us? The classic definition of hyperventilation is breathing too much so that your carbon dioxide level falls. Just like I was doing, where you kind of sit there and you pant and you pant and you pant, you're breathing fast, you're blowing off all that carbon dioxide, you're blowing it out faster than your cells are producing it, and so your blood carbon dioxide levels, that PCO2, drops. That is the clinical definition of hyperventilation. Now, how that affects a COPD population kind of depends on where your carbon dioxide level lives normally. If it is high, normally, then you're probably going to bring the carbon dioxide into a normal range. But again, think back to what I said a few minutes ago, that is also going to change your pH, and that's where the problem lies. So when you do hyperventilation, it's not necessarily a good thing because you're going to hyperventilate and affect your pH much faster than your kidneys can compensate for that, and you may throw yourself into a little bit of a metabolic issue. Now, fortunately, that will probably go away again as soon as you stop hyperventilating, because your carbon dioxide levels will build back up fairly quickly and get yourself back into that pH balance. Also got a question, where am I? We're in the group right here, got everything shared up properly, hopefully. So hopefully everybody is seeing everything come through okay, and everybody can hear me okay too, hopefully. So that's kind of a brief overview of how the carbon dioxide works and how the pH works and all that stuff. Again, very brief, and if you have more questions or need me to go into any more detail, I'm happy to do that. Do want to touch on a couple of other things, though, that have come up in the last couple of days. First of all, I do want to mention that this stuff usually comes out of, like I said, an arterial blood gas, an ABG. We draw blood from the artery. Generally speaking, it's from the radial artery right here in the hand. Sometimes if they're trouble with that, we'll get something for more of a brachial thing, more farther up the arm. Sometimes we can actually put in the intensive care unit, sometimes we can actually put in what we call an arterial line, where we can do routine sampling and things like that. We draw it from here because it's the closest artery to the skin, but there are some drawbacks to drawing from an artery as opposed to a vein. First of all, your arteries tend to have a lot more muscles than your veins do, and a lot more nerves, so it tends to be a little bit more painful. It tends to make when you have an irritant in there, it will make the artery kind of spasm down a little bit. Makes it a little bit harder to draw the blood. That's why this is not necessarily a routine blood draw. This is something we want to do generally only when there's a clinical indication for it, like if you're having trouble, if you're in the ER, if you're in the urgent care, something like that. There is some argument out there, some philosophy that we want to do when we know somebody has a chronic lung condition and is going to need ongoing monitoring. We do sometimes want to do it on an ongoing basis, maybe once a year, once every 6 months, things like that, to see if the level of carbon dioxide retention is getting worse, because that can be an indicator of worsening lung disease. But this isn't necessarily something you're going to do with routine lab draws, certainly not anything like doing blood sugar or anything like that. Probably not even at the level of doing like metabolic panels, or the white blood cell counts, red blood cell counts, those sort of things, because there is a little bit higher risk to doing it. Again, this is a very sensitive area with a lot of nerves, a lot of muscles, and it's also an artery. The blood comes out of there, it can come out a lot faster than it does with a vein. So there's a lot of potential for complications like hematomas, blood under the skin, which can cause problems, pressure problems in and of themselves. So sometimes we do want to do what's called a venous blood gas, and this is specifically what came up in the group earlier this week. The idea that you can draw blood, you can get the same types of information from a venous sample as you can from an arterial sample. The advantage of a venous sample is that it is a lot easier to draw. Usually a nurse or a respiratory therapist is going to be the one that's drawing a blood gas, whereas a phlebotomist who may have a little less training is often the one that will draw your venous blood samples from your more traditional sites that you would normally get blood drawn from. Because veins don't have the musculature or the innervation, to throw a medical word out there, the amount of nerves out there that veins do, or that arteries do, veins are usually a little less painful to draw from, and they're a little bit easier to draw from. However, a venous blood gas is by its nature going to be a bit less accurate than an arterial blood gas, because this is again kind of the waste stuff. This is the train going back to the station of the lungs to get to blow off the waste products and bring in the oxygen. You were going to expect your CO2 to be a little bit higher. We're going to expect the pH balance to be a little bit different because of that. And we're going to expect your oxygen level to be significantly different. Obviously, it's after you've used all the oxygen, or as much of the oxygen in your blood as you're going to use, so it's going to be much lower. We have found that in the setting of chronic lung disease, chronic diseases, venous blood gases can be an acceptable alternative for trending and things like that. However, if you are acutely ill, their correlation is much less, and they're much less sensitive to changes in your condition. In addition, we see that the oxygenation status is pretty much meaningless on a venous blood gas, because there are such differences in how much oxygen your tissues take up as they're going through the circulatory system. There's not really any correlation at all between the oxygen status on an arterial blood gas and the oxygen status on a venous blood gas. So they're really good for the pH, pretty good for the CO2, but we don't use them at all for the oxygen status. The last thing we can do to figure out somebody's at least one part of the picture of their pH status or acid-base status is we can actually look at what we call the end-tidal carbon dioxide. This is something that's popped up in the group once or twice. I know we've got at least one group member, Bonnie, who gets this tested out from time to time. Traditionally, we've only done them on patients who have a breathing tube in and are on a mechanical ventilator, because it's a much easier and almost continuous way to keep an eye on their carbon dioxide status. As devices are becoming slightly less expensive and a little bit more portable, we're seeing that some places are using them out in the field a little bit more. Paramedics are tending to carry them in the ambulances, again, usually for emergency situations. To determine whether CPR is being effective, to see if somebody who's having a seizure is breathing effectively. We haven't quite figured out to a great clinical guideline degree what the role of non-invasive carbon dioxide monitoring is for the management of chronic disease. So there are some places that are using it, some doctors' offices and pulmonary rehabs and stuff like that are actually using it on a somewhat routine basis to kind of keep an eye on things, kind of track how things go. But we're not entirely sure what the role of that is going to be and how well that's going to impact care down the line. Remains to be seen. So hopefully we'll get some of that information very soon. Let's see. Hopefully we can get somebody who's having a little bit of technical issue finding the stream today. Hopefully that will help them get on board a little bit more. So that again is kind of our main topic of the day. And as for those of you who may be new to the system here, we do about a half hour of the topic of the day, and then we do a half hour of question and answer period. This is kind of an open topic time. I am going to go back and scroll through and say hello to everybody that I missed earlier on. Diane, Linda, James, Noah, great to see you here again. Congratulations, Noah Greenspan, of course, recently published an excellent resource book on a variety of pulmonary diseases, and so congratulations for that. And we do have, and John says, John hits Mike, which is a little bit unfortunate, but looks like that was an autocorrect issue, so I won't hold that against you too much. And we'll let that one slide this time around. I won't hit back, I promise. So Rebecca does ask us, I breathe very shallow and was told yesterday I am a CO2 retainer and need to sleep with a question mark machine to pull it off. Does that sound right? I'm guessing that your clinician probably told you you need to have a BiPAP machine or a bi-level positive pressure machine, something along those lines. They may have used a brand name like Trilogy or something like that. But basically the concept there is when you have chronic lung disease, it of course, depending on the type of lung disease that you have, it can be a lot more difficult to breathe. So of course it's going to be a lot harder to blow off that carbon dioxide. A lot of times what we see is emphysema forms of the disease, we see that the lungs get a little bit bigger, sometimes a lot bigger, but the main muscle of breathing, which is the diaphragm, sits kind of right below the rib cage here. That main muscle kind of flattens out and works a little less efficiently. And so it's up to some of the other muscles in the upper chest, what we call the thorax, kind of take over some of that work. Unfortunately, that's not what they're really designed for, so they're less efficient at it, and so they get tired a lot more easily, and that kind of drags everything down. And so what we see, that can lead to some of this shallow breathing. And so what then happens is we want to add on to that. We want to add on to your breathing ability so that it's easier for you to blow off some of that carbon dioxide. And that's where this whole concept of bi-level positive pressure comes in. A lot of times we use CPAP machines or continuous positive airway pressure to treat things like sleep apnea, where the airway can kind of close off a little bit when you go to sleep and cause dips in oxygen and build up of carbon dioxide and that sort of thing. Sometimes that's not entirely enough, and we need to actually give a little bit more oomph and take some of the load off the respiratory muscles, so we actually have a machine that keeps a continuous level to help keep the airways open, but then can sense when you breathe in and gives you a little bit more pressure to help force some of that air in, some extra air in, open up the airways a little bit more, and then relax so that everything can flow back out. And that's what we call a bi-level. Bi-level positive pressure, because we have two. We have the continuous level and then we have the inspiratory level to help take some of that load off and take a deeper breath so that you can flush out a little bit more of that carbon dioxide. And I suspect that's what Rebecca's person is talking about here. It's not necessarily pulling off carbon dioxide. I don't really like that terminology, but it's helping you flush things out, helping you blow off some more of that carbon dioxide, and that can help get some of the things back into whack here. Because while your system can compensate for actually sometimes impressively high levels of carbon dioxide, it's still not great to have that in there. Anything that is kind of out of the ordinary is not ideal. And so if we can bring the carbon dioxide levels down as low as possible, we can kind of keep things close to that normal range and keep everything where we want them to be. So let's see. Bonnie, I'm not sure I quite understand. Bob makes a Harry Blackstone Jr. joke that I'm not 100% sure I understand, but we'll roll with that. Bonnie tells us that once she went vagal, what happens there sometimes when you cough or when you bear down a lot, it's what we call a vagal maneuver because it stimulates the vagus nerve. So if you were to go like kind of bear down a lot like that, you put pressure on this nerve, which then as soon as you release can kind of decrease your blood pressure. And a lot of times that's a suspicion for example, what happened to Elvis. He kind of vagaled down and then he kind of passed out and then aspirated, I think, some of his own vomit. But at any rate, hopefully nothing like that, nothing as extreme as that happens to anybody out there. But it can happen. It can affect your level of consciousness, make you pass out, fall down, hit your head, that sort of thing. That can also happen sometimes with these kind of, when drawing a blood gas, looks like that's what Bonnie's mentioning here. In Pennsylvania, they numb the area first with a shot while getting a ABG drawn. Never had that before, why not do that? That's pretty uncommon for a couple of reasons. First of all, if we're going in with a needle, and whether it's a needle for a blood draw or whether it's a needle for the anesthetic, we still run the risk of triggering that nerve. And so then we're basically giving you 2 needles for the price of 1 and doubling our risk of hitting a nerve. I suppose there could be some argument for a topical anesthetic, things like that. Usually, though, you run the risk, like I said, of double tapping a nerve there and causing some other issues. So we don't generally use a lot of anesthetic there. It's also, there can be some drawbacks as far as making you can have a sensitivity. We're also trying to keep the area as uncontaminated as possible. Hopefully we're doing a little bit, usually we're doing 2 different kinds of swabs on there. Sometimes an iodine, sometimes a povidone, I think it's called. Sometimes just regular alcohol, and we're trying to make the area as clean as we can. And so, of course, if we introduce things on there, then that can cause issues too. So usually we rely on the skill of the clinician to minimize the pain. And it really depends on the person too. It's going to depend on the individual's anatomy, how painful it is, and what kind of issues that crop up there. So that's a long way of saying that we don't do it because we don't want to. It's usually more trouble than it's worth to numb up that area. So we're looking for some other questions here, so please feel free to in the comment section here, please feel free to ask any questions that are on your mind out there. It doesn't necessarily have to be due or connected with the topic of the day, blood gases. Of course, we certainly welcome those questions, but anything else that's on the mind of the COPD community, this is kind of an open forum time to get any of those questions answered. In the meantime, while you're getting some of those other things up there, Karen did have another question from right before the show here. What is it about the high mid-afternoon through sunset sun that is so bothersome? Is it the ozone generating effect, or is it something else having to do with light? It's an excellent question. My suspicion is that I'll be totally honest, I don't have a 100% accurate answer for you on that one. My suspicion is in large part due to the ozone and in large part due to the overall heating effects of the sun. We tend to look at noon as kind of the time of day that the sun is highest in the sky, and we think of that as most intense. But usually our highs tend to run, especially in the summertime, more along like the 2 o'clock to 4 o'clock time frame. And so the sun may be most intense overhead at noon, but we don't get the effects until later on in the day. We could talk all day about physics and why that works and all that stuff, but the practical answer is it tends to be hotter in the later afternoon. We also oftentimes see humidity levels rise, and that's kind of why we have those summer thunderstorms that tend to happen later on in the day. And so I think the issue is less to do with the light and more to do with the heat. And then ozone certainly does have a component to that as well. And then just to wrap up Karen's last question here, will we be rescheduling the Light Facebook Live? Again, I had hoped to record some of our Shining the Light on Lung Disease seminar, which didn't necessarily have to do with light per se, but rather taking lung disease out of the shadows and bringing it into the light. It was kind of a whole metaphor thing. We've got a really cool, went all the way with the metaphor to the whole lighthouse thing. Trying to find our way with lung disease. So it's not necessarily a light-oriented talk, and as far as rescheduling it, unfortunately that won't be possible until next year. But hopefully by then we'll have a little bit better technology on board that we can live stream even more of it. And I'm even hoping to live stream some of the patient expo that we have coming up in the spring. So we'll see what happens. So next up, Jenny asks us, how effective is the use of an a cappella breathing device? That As it happens, I just so happen to have an acapella here in the office with me. This is an excellent tool for helping clear out some mucus and also giving some airway resistance. For those of you who may not be familiar with the acapella, this is basically a valve. It's a little bit difficult to see in this particular model because it is translucent instead of being transparent. But the concept is you blow out, you can adjust the resistance against this dial here. You get a little bit of resistance that helps open up some of the airways, kind of like we were talking a little bit earlier about the CPAP machine, helps open up some of the airways on a little bit shorter term basis. But you also get a fluttering resistance that sends vibrations back down into the airway and helps loosen up some of the mucus in there. It sounds a lot like this, if you can hear it. It's kind of that fluttery, vibrating sound. All that those waves get transmitted down into the lungs, hopefully knocking loose some of the mucus and allowing it to be coughed up a little bit more easily. This is a little bit older device. Some of the newer things on the market are things like the Aerobica, which does basically the same thing. This one is kind of fun because you can actually take it apart and show how it works. You blow through the mouthpiece here. It's got a little bit of a diverting thing, and it makes this vein flap back and forth, causing some vibration and generating that vibration that goes down into the lungs. As far as how effective it works, it's going to depend specifically on the kind of COPD that you have. If you have a lot of mucus, if you have a lot of trouble coughing it up, if you have a lot of phlegm, junky kind of stuff, then it's probably going to work very well. That's kind of what they're designed for, is to break that stuff loose and make it easier for you to cough it up, and thereby relieving some of your shortness of breath, hopefully. If you have more of the emphysema type of COPD, where you have the actual damage to the lung tissue, the alveoli kind of stretched out a little bit, the big lung, sometimes people call it, it may be a little less effective because you're getting, while the resistance may be good in helping keep some of the airways open and blowing off some of the stale air, the vibration probably isn't going to give you a whole bunch of benefit. Usually people end up somewhere along a spectrum with some elements of emphysema and some elements of chronic bronchitis. So it's really going to be individualized to your particular disease process. As far as what might be more effective between the acapella and the Aerobica, depending on which company you look at, they of course have a study that tells you their device is a little bit better. They do work on roughly the same concept, so in many cases they're going to work roughly the same. They do have certain advantages back and forth, like particularly the Aerobica. It's a little bit easier to clean, a little bit more dishwasher safe. So it's really going to depend on your needs and your preferences, to be honest with you. Bonnie asks, can you explain the simple terms, the difference in AVAP and IVAP? That's some terminology that is going to be a little bit dependent on each company likes to come up with their own terminology for their various things. And so I'm looking up the exact definition of, because I don't want any company to get mad at me here. AVAP IVAP is intelligent volume assured pressure, and AVAP is average volume assured pressure support. So when we're talking about intelligent volume assured pressure, that we're looking at more of traditional BiPAP has been targeted toward absolute pressure. No matter what, no matter how long you breathe, no matter what your respiratory pattern is like, as soon as you trigger that device or that machine, it's going to give you, say, 15 centimeters of water pressure, air pushed into your lungs. Regardless of whether you take a breath like this or a breath like this, you're going to get 15 centimeters of water pressure. What these more volume assured, volume targeted kind of devices are like the newer, I think the The hot topic right now is the Trilogy device. Those are going to be able to vary the pressure a little bit more depending on your exact breath profile. Some devices use one breath, the immediately preceding breath. Sometimes it's an average of a couple of breaths. Again, this is going to depend on the manufacturer and their particular strategy, but it's going to give you more of an amount of air so that if you're actually taking a deep breath, it's not going to kind of blow your doors off, basically, like that old, I think it was a Memorex commercial where you kind of sit there and all the music is blaring. And sometimes when we get a little bit crazy with the pressure settings, we get stuff blowing in the face so much, it's very uncomfortable. The whole concept of targeting to a volume rather than a pressure, it makes the machine a little bit more adaptable to the person and gives a little bit more benefit to a little bit more comfort, I should say. So hopefully that's what you were looking for as far as AVAP and IVAP there. Does the acapella device also improve atelectasis? Thanks, Bob. The acapella device can kind of on the short term help with atelectasis. Anytime you're exhaling against resistance, you're potentially opening up some of the airways. The concept of atelectasis is where you have lung units, the alveoli, the little air sacs in there, closed down because they're not being used properly or because they're being pushed on by other lung units, less healthy lung units, or they're closed off by disease process or mucus or what have you. And so when enough of them close down, you get this concept of atelectasis. And of course, when they're closed down, they're not doing any of the work of gas exchange. The good air isn't coming in, the bad air isn't going out. You basically just have this useless part of your lung. And so what we want to do is get those players back in the game. We want to open up those lung units so that we can actually get oxygen in, carbon dioxide out, and make your lungs a little bit more efficient altogether. And so the best way to open those lung units out is the appropriate application of pressure. And that's why we use a device like an acapella or an aerobica or even older ones that aren't so tied in with vibration and just give you resistance to open up some of those airways. A lot of times we'll put somebody on some CPAP or something like that, or we'll raise, if we have run into that, a lot of times in the intensive care unit, we'll increase their level of end expiratory pressure so that we can start moving that pressure through the lung and get everybody back exchanging gas again. So the short answer is yes, the acapella device can improve atelectasis, but unfortunately it's one of those things where we see that it's relatively short term. Obviously we're not breathing through the acapella all day long, and so we're still going to want to get up and do things like cough and deep breathe, get up, move around a little bit more, and we want to open up the airways with a device like an acapella, but then be mobile and keep everything moving so that they stay open, because that's really going to be the key. Ruby asks, could you use a glass of water, put a straw in it, and blow? Would that help with mucus? It's an interesting idea, actually. I don't know that we've ever talked about that in any of my clinical settings or anything like that. That's kind of a cool idea, though. But it does give you the pressure. It does give you the vibration. I, off the top of my head, don't see any compelling reason that it wouldn't work. That's kind of a cool idea. I might have to integrate that a little bit more. Of course, you're going to want to be careful to not overdo it, because you don't want to suck back in on the straw unexpectedly and get any of that fluid down into your lungs, because that's going to be a bad day. But I think if you're careful and you don't have any other alternatives, I think that would probably be worth a shot. So thank you for the idea, Ruby. Debbie asks, what is a safe O2 saturation with oxygen 24/7? And this is one of those questions that comes up all the time with a lot of clinicians, because we have this idea called the hypoxic drive. And it is one of those things I wish I could go back in time and unpublish whatever paper it came out in a long time ago, because it's one of those great myths, of pulmonology. We had this idea that as we've touched on today, as people build up, the theory is your main drive of breathing is high CO2 levels, high carbon dioxide levels. Well, of course, people with lung disease have high carbon dioxide levels all the time. And so the theory is when you have this kind of obstructive lung disease, you get caught, or you switch over to this idea where instead of high CO2, it's actually low oxygen that makes you breathe. So then, of course, what do we do when people have advancing lung disease? We give them oxygen, and we never allow their oxygen level to drop. And so thereby, we have this idea that if you give somebody with lung disease too much oxygen, you're going to knock out their drive to breathe, they're going to stop breathing, they're going to pass out, and then they're going to make your day really interesting. Unfortunately, this was the theory came out as a misunderstanding of some of the cause and effect relationships of chemistry and physiology inside of your body. And so over time, we haven't been able to replicate this idea. It's not something that happens. We do see that as people are on oxygen and we're treating some of their disease processes, their carbon dioxide levels do sometimes increase. Because of I'm not going to go into the details. If you want to really get into some of the technology of it, you can look up the Haldane effect and really understand a little bit more about how carbon dioxide and oxygen works in the hemoglobin metabolism. We'll throw a whole bunch of tech words out there. We'll bring in my Star Trek technobabble there a little bit. But what we see is that it's not necessarily the cause, but more of an effect. And so, but still this idea of this hypoxic drive has persisted for a very long time, to the point where sometimes we see people in real trouble with very low oxygen who are being starved for oxygen because we're afraid, because certain clinicians are afraid to turn their oxygen up and help them. And so we have this idea of what is a safe oxygen level. And the answer is going to tremendously vary from person to person because COPD in particular is a very individualized disease. And so what is safe and effective for one person is not necessarily effective for another person, for someone else. What we do try to do for practical purposes is we like to keep somebody who is on supplemental oxygen all the time around the range of, call it 92%. And we do that because once you start getting higher than 92%, you're not really getting a lot of benefit as far as your physiology goes. You're just burning through your oxygen a lot faster. This is particularly important when you go on portable oxygen, whether you have a portable concentrator, whether you have oxygen tanks. We don't necessarily want to keep your oxygen much higher than about 92%, because once you go higher than that, it's kind of a waste. Now, there are people who still have chronic lung disease who are on supplemental oxygen all the time and are adapted to a saturation of, let's say, 95 or 96%. In those people, if their saturation were to drop to 92%, which is still technically physiologically safe, they may feel short of breath and they may feel uncomfortable. In those cases, we would probably want to make sure that we're treating them appropriately and keeping their saturation up around 95%, because that's where they're comfortable, that's where you're adapted to, and that's what you're used to. And that's where your body wants to be. And so we really shouldn't necessarily have a hard and fast dictate about what is safe beyond what we know to be minimally safe for human survival, which is 88%. It'll give us a little bit of a buffer, call it 92%, and that's going to be our main target for most people. But again, this is going to vary tremendously based on your activity level, your own personal physiological needs, and things that your clinician should be addressing with you at your appointment. So please don't change your oxygen settings based on anything you're seeing online, including here, because a lot of this stuff is going to depend on your own individual physiology. But also don't be too afraid of this whole idea of hypoxic drive or anything like that. There are certain people that it does happen to, but it's more like having an allergy where it's an extremely rare situation, and we don't necessarily want to base our entire clinical practice on it. So, as Bob mentions, blowing a straw of 5 centimeters of water pressure naturally. That's a very good point. We're measuring. That's how we measure our are pressures in centimeters of water. And as a matter of fact, if you go inside a neonatal intensive care unit, a lot of times you'll have stuff being blown into, you'll have air blown into a column of water and then blown into the baby's nose, what we call bubble CPAP, which is basically keeping those airways open and giving a little bit of stimulation. I don't necessarily see why, I don't necessarily know that it's going to help you with mucus clearance, but it should help keep some of those airways open. Adrienne, varying O2 levels, portable concentrator, no longer pay attention to numbers. It's important to at least have a ballpark awareness, in my opinion, of course, of where your numbers are, because again, we don't want to see you getting below, for example, 88%. That's kind of our standard Medicare clinical guideline for when somebody needs supplemental oxygen. We don't want to see somebody dropping below that too often, because that's where we start getting into the realm of where we're having heart impacts and increasing your risk for stroke and things like that. But again, don't necessarily get caught up on them. From a clinical standpoint, there's about yay much difference between 99% and 94% saturation. So it's good to not necessarily get too hung up on them, but you do want to pay attention to them a little bit, again, in my opinion. Bob, with some great questions today. When we check out saturations, is there any variations across different machines? Yes, absolutely. I generally, for a long time, I was not a fan of people having their own pulse oximeters at home. A lot of reasons for that, but most importantly is oximeters tend to be very easy to fool. They're very sensitive to changes in perfusion. They're sensitive to changes in ambient lighting. Some models are even sensitive to nail polish and things like that. Technology has improved, and a lot of these devices have technologically improved to the point where it is often a good idea for people to be checking their saturations at home. But you do need to be aware that various devices do have different sensitivities and different quirks. Unfortunately, this is one of those things where you kind of get what you pay for, and the best oximeter to have is one of the clinical models from a company like Massimo or Nanan, where they're measuring different wavelengths of light, different frequencies, and doing a lot of computer algorithm-based signal interpretation, cutting down the noise, boosting the signal, that sort of thing, giving you a very accurate reading of what your saturation would be. We see that some of the cheaper models can be fooled by movement. They tend to be less sensitive to movement. They tend to be less sensitive at lower saturation levels, so exactly when you need them the most. So it can be tricky with some of the cheaper devices. It's good to have them, but you also have to be aware of their quirks and be aware that there are significant differences between machines. At the very least, you should be taking your device into your clinician's office and making sure that even at least at rest, it's correlating fairly well. Ideally, you'll be able to measure it while you're exercising and get an idea of how accurate it is under stress, so to speak, but making sure that things are going as they should be. So we've got a couple of minutes left. If there are any other questions out there, Adrienne, common sense is good. Follow what you're saying. Absolutely. Common sense ain't so common anymore, as they say. I am a big believer that in many cases you are the first person to know when there's something going wrong with your illness, with your body in general, and all that stuff. So listen to your body in most cases. This is very applicable when we're talking about activity, or when we're talking about when you start feeling sick. A lot of times you can just kind of start having this feeling of, man, I think I'm getting sick, and oftentimes you are. So use common sense, use your clinical tools that are available, like an oximeter, use them as tools. Don't necessarily just rely on one or one over another. Use the whole picture. That's what we do as responsible clinicians. We look at the entire picture of a person, and if we get one situation where one number or one device is telling us some outlier data, we want to make sure we don't necessarily treat just based on that, but we treat based on the entire sense of the person. So We'll probably go ahead and wrap things up here. Again, if you're new to the show, we do this every Friday at noon Eastern, technology permitting. We have our topic of the day plus some good open discussion time afterwards. If you are more interested in the COPD community in particular, or information about living well with COPD, I invite you to come check out our Facebook group, COPD Navigator, which is at facebook.com/group/COPD Navigator. We're here all the time for support, for information, for clinical questions. Of course, we're no substitute for your primary care provider or your pulmonologist, but we can certainly give you the information you need to ask the right questions and empower yourself to improve your own care. So with that, hope everybody has a great weekend. Hope everybody breathes easy out there. Oh, Tracy, yes, one last thing before we go. Flu shots are available, and flu shots are a critical component of COPD management, or really any lung disease management. They are one of the top recommendations from groups like GOLD, the Global Initiative for Chronic Obstructive Lung Disease, and they work very well. They are, while people will tell you that they're not foolproof and you might want to roll the dice with them, even in years where the strains don't necessarily line up to the what become the active strains, flu shots do tend to make, if you do catch the flu, it tends to be a little less severe and a little bit shorter. And of course, when we're talking about situations where flu can put you in the hospital in certain populations, Rachel, yes, I do see you typing there. But when we are seeing, when you do see that the flu can put you into the hospital, we want to keep that as minimal as possible. So get your flu shot, and if you're eligible for the various pneumonia shots that are out there, depending on when you've gotten yours last or your age, depending on the CDC criteria, make sure you're getting every vaccination you can to help protect your lungs as much as possible. So with that last little soapbox, thank you, Tracy, for the reminder. That was very important, and I do passionately believe in that, if that's not clear. And with one last hello to Pam, coming in late after her doctor's visit. I think she was getting, as a matter of fact, getting some information about her last ABG test. Hopefully we'll see everybody next week, noon Eastern on Friday, where we'll tackle another topic of COPD, and we'll breathe easy together. So thank you very much. Have a great weekend.